morning. So if everyone is able to join us back and switch on your cameras and we can get started. We're lucky to have one of our former residents and now ID fellow at UCLA, Dr. Olivo. I'm here to talk to us about endemic mycosis whenever you want to get started, and thank you so much for joining us.
Okay, perfect. Thank you to all the chief and Dr. Osorio. So yeah, today I will be talking about endemic mycosis. So for today, the lecture will be divided in three phases. So first, we will be talking about definition and basic concepts of mycology. After that, we will be talking a little bit about fungal testing, and in the last part, we will be talking about endemic mycosis cases. So what are the goals of this lecture? Application of fungal tests in your practice, some of them. So obviously we don't have time to review all of the fungal testing, but I think that the main ones that we see and we check in internal medicine, we can review them. The other thing is learning a simple clinical approach to endemic mycosis, and I will be presenting some cases that you will see in real life or in your internal medicine boards. So what are fungi? So these are eukaryotic cells, non-vascular, they lack chlorophyll. So they cannot really do photosynthesis. The cell wall is the antigenic area of the fungi, and the capsule of some of them, like Cryptococcus, will be the main virulence factor. So how can we divide fungal organisms? So they can be yeast, like the one in your superior right corner. They are usually unicellular and they divided by budding. Or you can have molds that they are usually multicellular colonies that divide through a longitudinal extension. And the ones that we will be talking today are the dimorphic fungi, and also called endemic mycosis, that in an environmental temperature, they can behave as mold, but inside of the body, they behave as yeast. Something that you should know is if you see that a lab test says pseudohyphae, so that just means that the yeast have some kind of incomplete budding. So you can see it in the left lower corner. So if you have incomplete budding, you will create a pseudohyphae. That doesn't mean that this is a mold. So if you see pseudohyphae in the respiratory cultures or pseudohyphae in your urine cultures, this is not a mold. This is most likely candida. So based on morphology, let's just go through the basic fungi here. So yeast, molds, and dimorphic. The most frequent yeast is Candida and Cryptococcus. The most frequent yeast-like fungi is Pneumocystis, and for the molds will be in our hospital. I think that Aspergillus will be the main. And in some occasions, you may say Mucor or Fusarium, depending if you are dealing with neutropenic patients or decay patients. Dimorphic fungi will include most of the dimorphic fungi, most of the endemic mycosis. So Histoplasmococcus, Blastosporothrix, and Paracoccus. So let's start with the first question. So which of the following patients needs a beta-D-glucan? A patient living with HIV with a CD4 of 50 who comes to you with subacute dyspnea. B, a patient that was diagnosed with COVID 1 month ago that didn't receive any treatment. So no steroids, no tocilizumab, no baricitinib, that comes with fevers and a CT without any changes. C, a patient living with HIV who comes with a CD4 of 50 coming with lung nodules and chronic meningitis. A patient with DKA fevers with a black scar in his nose, or A and B. So I think that Gunish was going to activate the poll. Yeah. Let's give it, it's an easy question, so 40 seconds.
So 15 people. So.
Hello, Dr. Olivo.
Hi, Dr. Andrelli, how are you?
Nice to see you. Thank you for doing this.
Yes, no, thank you. Okay, so most of the public answer A, 52%. The second most common answer was C, with 24%. So yeah, the right answer here is A. So this is a patient with pneumocystis gyroH pneumonia, and this is actually one of the cases that we usually send a beta-glucan. So what is the 1.3 beta-glucan? So this is the cell wall component of many fungi. Something that you should know is that the sensitivity and the specificity of this test varies a lot depending on the host, and usually tends to be more sensitive in samples from the BAL, but even in the BAL, the sensitivity can go between 70 to 90%, and the specificity can go between 77 and 96%. The higher specificity for this test is for invasive fungal infections in patients with heme malignancies. So the use of this test should be directed to rice hosts. For example, patients with feral neutropenia or patients living with HIV with CD4 less than 200 if you are looking for a pneumocystis gyroH pneumonia. Something that you should know is that in 99% of the cases, if you have an infection with Cryptococcus, Blastomycosis, or Mucorales, the beta-glucan will be negative. So in general, there's no cross-reaction with this fungi. So what are the limitations of this test? So as you know, beta-glucan is presenting in PJP, Cocci, Fusarium, Histoplasma, Trichosporum. So there is a lot of fungi that they have this cell wall component. So you cannot really be specific when you try to make a diagnosis with this test. The other thing that you should know is that we can have false positive results with semi-synthetic beta-lactam antibiotics, especially Zosyn. Since 2010, the formulations of the antibiotics, they have been changing. However, we still see cases of false positive results in patients that are receiving a piptazo or a Unasyn. You can also see it. The other thing that is really important that you should know is patients who are receiving immunoglobulin infusions, they can also have false positive results. So this is just a study just to show you how variable can be this test. So this is a cohort of cancer patients. So let's go to the first line of confirmed cases. So if you see here, approximately 73% of the cases with PJP in patients with cancer, they will have a beta-glucan more than 500. However, you may miss close to 30% of the cases. So you need to be careful and you need to do a clinical correlation. And usually, if you don't have something that looks like PJP, you shouldn't be trusting in your beta-glucan. The other thing that you should know is in this cohort, so 85% of the cases that they were diagnosed as possible PJP, they have a beta-glucan less than 79. So let's go for the second question. So which of the following patients needs Aspergillus galactomannan antigen? A patient living with HIV with a CD4 of 50 with subacute dyspnea, a neutropenic patient with subacute dyspnea and necrotic lung nodules, a patient with COVID-19, no treatment, but with fever, sensitivity without changes, a patient with HIV coming with lung nodules and chronic meningitis, or a patient with DKA fevers with a blood scar in his nose.
All of them. Oh.
Okay, so 75% of the public say the option B, so this is correct. So this is a case of a patient with neutropenia that is coming with necrotic lung nodules. So in this type of patients, we usually think about invasive fungal infections, especially invasive pulmonary aspergillosis. The reason why you shouldn't be sending in all of these patients is so patients who are living with HIV, they don't frequently present invasive aspergillosis. The other thing, if you have a patient with COVID that was diagnosed 1 month ago and didn't receive steroids, didn't receive tocilizumab, didn't receive baricitinib, invasive aspergillosis shouldn't be in your first three differential diagnoses. The option D, this a patient with HIV coming with a CD4 of 50 with lung nodules and chronic meningitis. If you're in LA or if you're in New York, this is most likely a disseminated cryptococcus. So for this disease, we don't send an Aspergillus galactomannan, and the last option is most likely a mucormycosis case. So in this case, also we don't send Aspergillus galactomannan. So what is a galactomannan? It's a major polysaccharide in the Aspergillus cell walls. The test can be done in serum and BAL, as the beta-D-glucan, the sensitivity in BAL tends to be higher. Something that you need to be careful is, even if you have a positive galactomannan, that doesn't differentiate if you're colonized with Aspergillus in your airways or versus you actually have invasion of the Aspergillus. So in what type of patients do we usually use this test is for invasive aspergillosis in heme malignancy patients. The other thing that you should know is also positive for histoplasma, fusarium, and penicillin. This has some similar limitations to the beta-D-glucan, so you can have false positive results with semisynthetic beta-lactams, lysosine or unosine in hospitals that they use a plasma light for the BAL. So you can also have a false positive results. I don't think that we use plasma light in Morningside or West for the BALs, but if they use it, you should know that you can have a false positive result. And something that happened to me like 1 year ago during my liver transplant rotation. So I had this patient that he used to eat ice cream every single day. So people that is eating the ice pops or frozen desserts containing sodium gluconate, they can have false positive results. So be careful with that. Yeah, so this is a study done in liver transplant patients. The main thing that I want you to see here, so all of these patients, they have invasive fungal infections, but if you notice the sensitivity and the specificity of the galactomannan changes in different days with the same host, and all of these hosts, they actually have invasive, so they have invasive fungal infections. So be careful. If you have a negative test and you still think that this patient has aspergillosis, you need to start looking for tissue or Aspergillus PCR, or you should be using a different type of test. So let's go for fungal test 3. I think that this is the last questions for fungal testing. So which of the following patients needs a fungal culture, a fungal blood culture? And I think that this is something that I do remember doing a lot when I was an intern, sending fungal blood cultures, and I really never knew why I was sending fungal blood cultures. So A is a patient living with HIV with subacute dyspnea. B is a neutropenic patient with skin lesions on fluconazole. C is a patient with possible Coccidioides infection. D is a patient with possible mucormycosis. And E is a patient, I don't know if this can here. Is a patient with fevers and central line in the ICU. So which of the following needs a fungal blood culture? And if someone's would like to comment in this neutropenic patient with the skin infections, so what infection do you think that this patient has? For those that are going to hemon or they really like to go to Sloan Kettering. Okay, so 41% of the public show option B, that's the correct answer. 27% say E and 23% say D. So guys, so what infection is this patient having? The patient in the option B. I cannot really see the chat, so I don't know if someone is writing or not.
Anyone want to unmute yourselves or post in the chat?
Or if any of the chiefs, I know that we have 2 chiefs that are going to hemon, so they will see this sooner than later.
So Christopher in the chat is saying Cryptococcus.
So this is likely a patient with a disseminating a Fusarium.
I'm sorry,
Okay.
disseminated.
What?
Disseminated what? I couldn't hear.
Fusarium, F-U. Okay, let me type it. I cannot type in this chat. Give me 1 second. Fusarium. Okay, or Fusariosis. This is mainly seen in cancer hospitals, guys. So if you're not in a cancer hospital or in a place that does BMTs, you may not see this so frequently. So what's the use for fungal blood culture? So this is mainly used for monomorphic molds and for some dimorphic fungi. Something that you should know is that the main use in cancer hospitals is to check for Fusarium infections. So Aspergillus in the blood is extremely rare, and dimorphic fungi in the blood is also rare. And the other thing that you should know is, for example, for histoplasmosis and coccidioides sometimes can take 3 to 6 weeks. So if you have fungemia, you cannot wait 3 to 6 weeks to wait for those results. And the other thing that you should know is that most of the yeast can grow in bacterial blood culture, so Candida and Cryptococcus. So you don't really need to send a fungal blood cultures in a routine fashion. So you will notice that there are some articles in the literature that they say that if you use fungal blood culture for Candida and Cryptococcus, you may have a faster result. However, this is kind of like a controversial topic right now. And in general, you shouldn't be sending fungal blood cultures. The other thing that I want to talk about is about the histopathology of fungal infections. So this was a 10-year review study from the pathology department of Stanford. So so they got 300 samples, 300 biopsies for possible fungal infections, and they noticed that 47 biopsies were concurrent with a positive fungal culture. So something that they noticed was that 21% of the specimens were misidentified. So why this happens? So for example, let's say that you see these fungi in the lung here. So in this article, they notice when they describe this as an spherule. So on your lower right side, you can see what is an, so you can see the spherule, and this is usually seen with Coccidioides infections. However, when they did the fungal culture, they noticed that this was growing Aspergillus. So what's the learning point here? That sometimes, so depending on how do you cut the pathology sample, you may see different views. So imagine that this is an Aspergillus if you do a coronal view of the sample. However, if you do an axial cut, it will look like round structures, and someone will say, oh, this is a yeast, this is not a mold. So you shouldn't be trusting 100% in histopathology either. The other point that I want to talk about is imaging and fungal infections. So as you can see, so this was a great review of chastity findings in a University of Bologna in Italy. So they noticed that, for example, with Pseudomonas, you can see nodules. With Aspergillus infections, they can present just with pleural effusion. So in general, you should never be saying, oh, this looks classical for this infection, just because you can have different manifestations. And in general, we don't really have a classic findings for this. So the only way of doing fungal identification can be made by culture or next generation sequencing if that's available in your center. So now let's talk about endemic mycosis. So most of them are dimorphic fungi with one exception, there is a Cryptococcus gattiae. So why they are called endemic mycosis? Because they are usually found in a specific geographic regions with certain types of soils and certain types of seasons. The transmission of this fungi is mainly through inhalation. However, some of them can be transmitted through a cutaneous inoculation or via transplant. So this is just to see some general pictures of the endemic mycosis in their different phases. If you need to know or to remember 3 pictures, So I will say this for cocci, so the spherule. If you see an spherule in a test, this is cocci automatically. The second most common one that you will see in the boards is the steering wheel for paracocci. And you will see this, so your question will say something like, oh, patient coming from Brazil, from Venezuela, or from Colombia, coming with mucosal lesions and pulmonary lesions. And the other one that you should know about is the sporotrichosis that can present with a cigar-shaped yeast form. So how many endemic mycoses do we have in the US? So in the US, we have multiple, so Blasto, Histo, Cocci, Cryptococcus catii. We also have the sporotrichosis, and also a new one that is called Mycosis. So outside of the US, we have paracocci and Taxolarum. And the other thing that you should know is that in general, all these diseases, they have a global distribution. So actually you can see it in every single continent. So in the US, an easy way to remember this mycosis is, so what is west to the Ohio and Mississippi River, and what is east to the Ohio Mississippi River. So on the west side, so let's start with the Pacific Northwest. So in the Pacific Northwest, you can see Cryptococcus catii, and in southwestern US, you can see Cocci. And to the east, we usually see Blasto and Histo. Regarding sporotrichs, you can see it throughout the US. For Mycosis, we just see case reports, and they are mainly located in the Midwest. Sorry about that, guys. So what are the common presentations of this? So the ways that you will see this type of diseases in real life will be community acquired pneumonias that they are not resolving despite 72 hours of antibiotic therapy, and they don't really have any evidence initially of complicated disease. The other way that you will see this is chronic pneumonia. So this will be like a tuberculosis-like. And the other forms that you can see it is with disseminated disease, or if you see a cutaneous lesion after inoculation in the skin. So what are the key principles to diagnose this? So you need to know the immune status of your host, you need to know the location of your patient, and you need to know the exposures of your patient. They can be recent or a remote if you are thinking about reactivation of the disease. So now let's jump into the cases. So all the answers of these are based on the guidelines of 2021, published in The Lancet. This was on December 1st. So in general, I think that they are really reader friendly. So if you're interested in this subject, I think that you should take a look at them. And the other guidelines that we have are the ones for 2020 for disseminated histoplasmosis in patients living with HIV. So let's start with case one. And by the way, the first 5 cases, all of these cases are real life cases. So case one is a 69-year-old female from Lancaster, California, and this is how Lancaster looks, who comes with a history of 2 days of altered mental status and hemodynamically stable. The daughter reports that she had a pneumonia 3 months ago and was treated with levofloxacin. Since that time, she has been having chronic headaches. When she comes to the ED at Cedars-Sinai Hospital, you notice that an X-ray shows a left upper lobe granuloma, and just because of these chronic headaches and this new altered mental status, they went and they did an LP. So the LP show a lymphocytic phagocytosis, high protein. And if you see the MRI here, so if you see this area, so this is the area of the circle of Willis. So this is what we call in idea basilar meningitis. So I think that we can open the poll to see, so how do you diagnose this disease? With serologies, with urine antigens, with fungal blood cultures, with fungal respiratory cultures, or with CSF fungal cultures? And if someone wants to comment on what disease are we talking about right now? Oh, wow. Okay. That was surprising. So most of the public choose the option E, 36%, and 21% was divided between A, B, and D. So guys, what disease is this? So what is the name of this condition?
Anyone can post in the chat or unmute yourselves or guess.
So the most important thing here is, so this is a patient from California. So what do you think that the patient has?
Coccidioides is common in California, but it could also be other diseases like Cryptococcus.
Exactly.
Carlos is saying crypto in the chat, and Yasmin is saying histo ?
Yeah. So something that you should know is this patient was not immunocompromised. So I didn't mention anything about transplant. I didn't mention cirrhosis. I didn't mention diabetes. Yeah, you can have a Cryptococcus in immunocompetent patients, but this is rare. And if you see a question, so I think that in MEXA, what's the other thing? And you were, the question says, or Lancaster or Bakersfield. And that's what we call in LA a Cocciland. If you go there, you get Cocci, like literally. So this is Cocci. The initial testing is serology. So this is the only endemic mycosis that is diagnosed with serology. So this is kind of like a general important point here. The second question about this case is, now that you know that the patient has coccimeningitis, which of the following antifungals would you like to start in this patient? A, fluconazole, B, amphotericin, C, Cresemba, or D, terbinafine? Okay, so B, choose liposomal amphotericin. So the correct answer here is actually fluconazole. So something that you should know, guys, is in general, a liposomal amphotericin does not penetrate the blood-brain barrier well. So I know that we use it for Cryptococcus, and I am pretty sure that everyone say, let's use amphotericin because we use it for Cryptococcus or for severe fungal infections. However, most of the experience that we have for Cocci is with fluconazole. So the other thing that you should know is when we use fluconazole in these patients, like we're not going to use that dose that we use frequently, like 200 or 400. We will go up to 1200. Thank you. So in these patients, the initial therapy will be fluconazole. In the cases that you will use a liposomal amphotericin B is if the patient has rapid progression of the disease or if the patient is hemodynamically unstable. But in general, like we rarely use a liposomal amphotericin. Let me go here. So now you're a primary care provider. You work in California. Let's say that this is, I think that Angelica is in California. So let's say that now you're Angelica. You're working in San Diego and you see this patient in the primary care clinic. She has been taking fluconazole daily for 3 years. And she asks you when she can stop the medication. Currently, she doesn't have any side effects. Liver function tests are normal. So what you should answer. So let's say for those that want to do primary care and want to go to California. So I don't know how many of those are in the chat. But okay, so 52% of the public say option C and 38% say B. So, and most of the people say, now you can stop it because you have been taking this for 3 years. So something that you should know with Cocci, we never stop ASOLs. Once you get Cocci meningitis, you always have Cocci meningitis. So due to the risk of relapse, you will be for life in ASOL therapy. The other thing that you should know is, so apart of getting a worsening Cocci meningitis, the other thing that can happen when you stop the ASOL is, so patients, they can develop vasculitis of the CNS. and that can be horrible. So I have seen personally 2 patients with this. It's a nightmare. Like you need to place, so usually amphotericin be in the brain, so intrathecal amphotericin plus steroids. And so actually when you do that, so just injecting amphotericin in the brain, so you can get the secondary meningitis. So never stop ASOLs in cocci.
We just have one question.
Yeah.
Sorry, Kristen. There's just one question Eric's asking, even for patients without meningitis?
Yeah, that's a great question, Eric. So yeah, so patients without meningitis, so what we do, usually we will continue for 3 to 6 months, and we will be checking the antibodies. So if the antibodies go back to normal and you have a resolution of your pulmonary symptoms, and in the pulmonary imaging, in occasions, we will stop the fluconazole, but I will be going there in the next couple of slides. So you're on the right track, Eric. So cocci, this is caused by Coccidioides or Coccidioides posadaci. Usually this will be seen in southwestern US. And the general characteristics of the soil to have cocci, so this needs to be an alkaline soil. In California, usually we don't have a lot of rainy season, so usually you will be seeing that here. The other thing that you should know is that the cases continue to increase every year, and we think that this is because of climate change. Regarding transmission, the most common way of getting this is through the spores. So the spores goes into the lungs, and after that you have the dissemination of the fungi. However, you can also get it through cutaneous inoculation and through solid organ transplantation. Something that you should know, if you think that someone has cocci, you need to call the lab because persons who are dealing with the cultures, they can get contaminated. And actually we have seen people in the lab getting contaminated with cocci, so please be careful. So this is the distribution of Coccidioides. So this fungi will be mainly located in California and Arizona, in Mexico, in Baja California, Mexico, some areas of Central America. In South America, so in the north area will be in the deserts of Colombia and the deserts of Venezuela, some desertic areas in Brazil and Argentina too. So which are the risk factors for cocci? So first is your geographical location. If you live in California or in Arizona, you have risk getting cocci. The exposure usually will be someone was doing hiking in California, or someone went through like a dust storm in California, that they do happen here. So 2 to 3 weeks later, they will come with symptoms of community-acquired pneumonia. So which host can get severe disease? So patients with HIV, solid organ transplant, pregnant women, and the other 2 populations that you should know about is Filipino patients or Filipino descendants. They can get horrible disease and they don't need to be immunocompromised. The other hosts are in general African Americans or people from Africa. By the way, we don't really have an understanding why that happens. So all of this was noticed in an article from the 1940s from the VA hospitals, but we don't really understand why Filipinos and African Americans are more susceptible to this. So how do you see Coccidioides? So 60% of the cases in general will be totally asymptomatic. Of the ones that actually get symptoms, so most of them will get pulmonary cocci. These ones will be divided in acute and chronic. So what you should know about the acute cocci is that they present like community-acquired pneumonia. So fevers, chills, cough, chest pain. You do an X-ray, you may see a consolidation or you may see a nodule. The thing that you need to be aware in cocci is that they can have some manifestations outside of the lung. So always need to check the skin, and always you need to check the joints. In these patients, you may see erythema nodosum or multiforme. And chronic pulmonary cocci, this may present as a tuberculosis-like picture. So it will be a cavitary pneumonia. Patients may present with hemoptysis, chest pain, and in occasions, you may see a miliary pattern. The other phase of Cocci is a disseminated or reactivation. So your host here will be immunocompromised, Filipinos, pregnant women, or some patients that are African Americans. So, so where are you going to see the symptoms here? So you will see in the skin, you will see a lymphadenopathy, or you may see patients with meningitis. Regarding the diagnosis of Cocci, so how do you do the diagnosis here? So if you have tissue, you need to send for fungal stains and for fungal culture. If you see a spherule in the biopsy, so this is pathognomonic for Cocci. So if the pathologist is 100% sure that this looks like a spherule, you can start treating this patient as Cocci. In patients that you don't have a clinical specimen, serology is the test to go. So there are 3 types of serology. So the one that you do for initial testing is TIA, something that you should know that the amount of false positives for this technique is huge. So usually if someone has a false positive, we may confirm with a different type of serology. The other thing is patients that have a meningeal signs, they will, so they should have an LP to check for fungal meningitis. And all patients with Cocci, they should go through a chest X-ray or a chest CT. Regarding Cocci treatment, so if you have pulmonary disease, you will get fluconazole, or the other thing that you can get is itraconazole. So usually it will be from 3 to 12 months. However, in real life, what we do is if you don't see resolution of in your pulmonary imaging, you will be continuing with treatment. Or, for example, there are patients that the titers for the antibodies, they remain high. In these cases, we will also continue with the treatment. For meningitis, fluconazole is the first line agent. You will continue this for life. And for people who have rapid progression of the disease and they are critically ill, we may use amphotericin. Something that you should know is that we have criteria for treatment in pulmonary disease. Not everyone that gets Cocci gets treated for Cocci. I can give you an example. I don't know, like 9 months ago came this Turkish lady that came with signs and symptoms of community acquired pneumonia to UCLA. Her symptoms last like for 9 days. So I checked for Cocci, but when she came back to the clinic on the next week, all her symptoms were resolved. In this type of patients, we don't treat with fluconazole, we just monitor. And the last point here of treatment of Cocci is if you have a failure of the fluconazole, we may change to other azoles like Bori or Posa. And as a last resort, you may use intrathecal amphotericin for meningitis patients. So how is the follow-up of these patients? We usually do a serology every 3 months just to check for response to the therapy. We check chest X-rays frequently to make sure that they have a full resolution of their lesions. And if they have meningitis, they will get azoles for life. Now let's jump into case number 2. I saw this case on my first week in the ICU. Sun looks, morning, Sun looks at that point. This was a 32-year-old male, a patient living with HIV. He actually was a dancer from Cirque du Soleil from Brazil, who was admitted to the ICU due to shock and fevers. He was found to have mucosal lesions like the one that you can see here, this ulcer in the tongue, bilateral lung granulomas, and pancytopenia. You suspect a fungal infection, so which of the following is the best initial diagnostic method to diagnose this disease? And if someone wants to comment on which is the most likely condition here. Let's see who was answering before. Okay, so 53% say A, serologies, and just 13% say the urine antigen. So guys, just to remember from 5 slides ago, the only endemic mycosis that you diagnose with serology is Cocci. You don't diagnose the other ones with serology. In histoplasmosis, serology may have a different role, but I will be discussing that later. So yeah, so the best initial test for disseminated histoplasmosis is a urine antigen. The second question is, now you have this patient who is hemodynamically unstable with disseminated histoplasmosis. So which agent would you like to use? So I don't know if Dr. Osorio saw this patient or was Dr. Pfeffer, but I'm trying to remember who saw this patient.
I think it was Pfeffer. I remember the case though.
Exactly. Very good, guys. So this is a hemodynamically unstable patient who has a disseminated mycosis, in this case, histos. So yeah. So in these cases, you should be using amphotericin B. So now the patient is in the floors. He's not in shock anymore. He tells you when can he change to a PO regimen. So which agent would you like to use? Fluconazole, Bori, Cresemba, or Itra? And by the way, guys, I would say like 70% of these questions are actually in the MEX app. So I actually went to the book of the MEX app before doing this presentation. So, okay, I think that we have a tie here. So a 35% says fluconazole and a 35% say the itraconazole. Something that you should know is fluconazole actually is active against histoplasmosis. However, you need to use such a high doses that we don't use it in real life. So itraconazole is the agent of choice for this, for de-escalation or for patients who have mild to moderate disease. So histoplasmosis is caused by Histoplasma Taxolarum. So there is a different type of histoplasmosis called Histoplasmosis Taxolarum du Boise. So this is mainly in West Africa. We don't see that here in the US. The main difference between that one and the one that we see here in the US is that that one has a predilection for the skin and for bone infections. Histoplasmosis, you will see it usually in soil that is contaminated with bad guano or bear excreta. Transmission similar to the other ones through the lungs, skin. So if you have a direct trauma in the skin or in solid organ transplantation. The other thing that you should know about this is that this has a worldwide distribution. However, in the US, this is highly endemic to the areas of the Mississippi and the Ohio River. So in here, we can see the map for histoplasmosis. So the dark areas are the ones that are hyperendemic. So in here, so this is the area with the Mississippi and the Ohio river basins. Central America is huge for histoplasmosis. Salvador, Guatemala, Panama, those are like huge areas for histo. And the other areas that are also highly endemic for histo is the border between Venezuela and Brazil, the border between Suriname and Brazil, and in the area between Peru and Brazil. So what are the risk factors for this condition? So first, you need to be in the appropriate location. Second, you need to be exposed to soil. The classic question in the boards will be someone is doing a spelunking or walking through the cave and they see a lot of bats or birds and they come 3 weeks later with symptoms of a community-acquired pneumonia. So who gets severe disease will be patients living with HIV who are not controlled or patients who are recipients of a solid organ transplant. The other thing that you should know is patients with COPD, so they are extremely susceptible for a chronic pulmonary histoplasmosis. So the clinical manifestations of this will depend on your immune system. So something that you should know, so 99% of the cases are totally asymptomatic. The 1% that develop symptoms in the immunocompetent host will be self-limiting. And for the immunosuppressed host, you may develop chronic cavitary pulmonary histo, that this is similar to tuberculosis. You will come with night sweats, chills, weight loss, and it's usually seen in elderly males and COPD. However, these are statistics that you may see in the books. So this is referring when males used to smoke more than females. Now we're kind of equal in that. So yeah, so now the ratio is kind of similar between males and females. And the other two types of diseases that you should know in histo is progressive disseminated, that is the one that our patient has, or CNS histo, that this can be just CNS histo or can be part of the disseminated form. So in progressive disseminated, this can go to any organ. So there are two forms. The one that our patients have was the acute form. These patients, they may die within 1 to 2 weeks, so you need to work quickly if you think that this patient has histo. This is usually seen with patients that they have T-cell problems. The CD4 number range is usually below 150 and it's rapidly fatal. And the chronic one is usually in older adults. They can take 6 to 1 year to come to the hospital. So I have a patient from the VA that I have been following for 1 year now, but this guy, he was 1 year and a half with fevers and he didn't care. And he came to the hospital because he started developing shortness of breath. So something that you should know is that a disseminated chronic histo can take time to develop. So for the diagnosis, all your clinical specimens, this is really important to get tissue in these patients, to go fungal stains and fungal cultures, urine antigen. So this is useful in making a rapid diagnosis of probable histoplasmosis. The things that you should know is it's more sensitive for patients that have a disseminated histo or patients that have acute pulmonary histoplasmosis. If you have someone with a cavity and you think that the patient has histo, it's not super useful. Serologies are mainly used for chronic pulmonary histoplasmosis, and imaging should be done according to the clinical scenario. Regarding treatment, if you have advanced HIV or you have a severe disease, liposomal amphotericin. If you have mild to moderate disease, it's itraconazole, and the durations will depend on your host and the type of disease. Other thing that is important is controlling your immunosuppression. So case number 3, I saw this case in 2016 when I was in Panama. So 40-year-old male who works in a laundry comes to you with a complaint of skin nodules. He reports that he burned his finger. He used antibiotics and that didn't help. And he thought that was a good idea that his cat licked the wound. So yeah, this just happens in Panama. This doesn't happen in any other place in the world. So what is the best initial agent for this patient? And what disease do you think that this patient has? I think that we should go a little bit faster here. I have 2 more conditions to be done with. Okay, so C, yeah, so that's the correct answer. So itraconazole is the agent of choice for Sporotrix infections. So sporotrichosis is caused by Sporotrix. It's usually a subacute to chronic infection. It's mainly in tropical and subtropical areas. Transmission, so this is usually through skin trauma. However, you can have a zoonotic transmission. Of all the animals that can give you Sporotrix, the main one is cats. So we can have a multiple outbreaks due to cats. So regarding risk factors, you need to be exposed to soil or to a cat. You can get a pulmonary or joint issues without Sporotrix, and this is usually seen in alcoholic patients, or you can have severe disease in patients with immune suppression. Regarding the distribution of this disease is throughout the US. For immunocompetent hosts, it's mainly a cutaneous disease. The one that we saw is a lymphocutaneous disease. However, you have other manifestations of this condition like fixed cutaneous infection or a disseminated cutaneous infection. For immunosuppressed hosts, you may have cyclic arthritis due to this or primary pulmonary Sporotrix that this also looks like tuberculosis. Regarding the diagnosis, so for this one, we don't really have an antigen or serology, so you need to do a biopsy. Regarding treatment here, so the main one will be the itraconazole. Alternatives will be terbinafine. You need to be careful with this because this is a drug that can cause a lot of problems in the liver. And if you have patients with disseminated disease or pulmonary disease, you should be using amphotericin. Okay, case number 4. So this is a 39-year-old male with no medical history that comes to his PCP due to hemoptysis and fevers. He was in a family trip in Illinois. You sent him to the ED for workup. The chest X-ray shows a right middle lobe pneumonia. He was treated with levofloxacin. However, he returns back to you that you are his PCP with verrucous skin lesions. They do a skin biopsy that show a broad-based spotting yeast. So what is the best initial agent for this condition? Now we can show up the poll. Okay. A say high dose fluconazole, 55%, and 45% say C, voriconazole. So the answer here is itraconazole. So it tries the initial therapy for blastomyces. So let's talk a little bit about blastomycosis. So this is usually seen in soils that are close to freshwater systems. In the US, we see it mainly in the Mississippi River and the Ohio River areas. And also now we discover a new species in the western side of the US that is called Bastomizes Helicopters. So in here, this is also a global condition. It's mainly in North America and in the south areas of the African continent. Regarding the risk factor for blastos, so soil or water exposure. And the other thing is you need to be in the appropriate location. Regarding severe or disseminated conditions, patients living with HIV, solid organ transplant, or pregnant females. Regarding the clinical manifestations of these, 50% will be asymptomatic and 50% will be symptomatic. Of those, most of them will be pulmonary blasto. This can be divided in acute and chronic. This is kind of similar to the other conditions. So the acute is like a community-acquired pneumonia. It's usually self-limiting. The chronic behaves as tuberculosis with fever, night sweats, and weight loss. However, a percentage of these pulmonary infections may progress to disseminated. So 60% will have some kind of manifestation in the skin, 25% in the bone, and 5% in the CNS. Regarding the diagnosis for this, we do have a blastomyces urine antigen in the US. So this is actually sent to the same lab, to the ones that we use for histoplasma, to the histoplasma urine antigen. The things that we should know here is that the urine is more sensitive than the blood. So if you think that the patient has blasto, you should set the sample from the urine. For these patients, all of them, they should get a chest X-ray. For treatment, something that is important here and different from COX is that all the patients that got pulmonary blasto, they need to be treated because the risk of dissemination. So in severe disease, you may start with the amphotericin B, and you will transition to the itraconazole. Alternative is higher doses of fluconazole. So for those that answer fluconazole, you were partially right. However, we rarely use this in real practice. This is the last case. This was a super sad case. So this was a patient that came to the liver transplant center at UCLA. So 67-year-old female, renal transplant recipient that is coming with fevers, meningeal signs, skin lesions, and hypotension for 12 days. She resides in Washington State. She visited a community hospital 5 days ago, and they told her that she had a molluscum contagiosum. Which of the following is the best initial diagnostic method to diagnose this disease? This patient died actually, so kind of sad case. And I think that this case has like 5 learning points. Okay, maybe we can show up the poll. Okay, so 36% say PCR. So guys, what, and 27% say A, blood and CSF antigen. So what diseases do you think that this patient has? Someone?
So Patrick is saying crypto.
Exactly, very good. So, so this is a disseminated cryptococcus. So for this, the initial diagnostic method is blood cryptococcal antigen or CSF cryptococcal antigen. The other learning point for this is, guys, if you use PCR like in the CSF for the meningitis and the encephalitis PCR, that I think that we send in St. Luke's each time that we have someone that looks that they have meningitis or encephalitis, is just 70% sensitive for Cryptococcus. So you're going to miss 30% of the cases. I had born myself 2 times already saying, oh, the cryptococcal antigen in the meningoencephalitis panel is negative. This patient doesn't have crypto. 2 days later, throwing crypto in the blood. So be careful. The best test for this is the CSF and the blood antigen. So just a quick pearl here. All of these diseases can present with molluscum-like lesions, and all of these diseases can kill you within 2 weeks. So A is Taxolarum, B is disseminated Cryptococcus, and C is disseminated Histo. So let's talk about Cryptococcus gattiae. This is mainly in the Pacific Northwest. So the way that they will present the question, they will tell you this is a gardener. He works with eucalyptus trees, and he starts having nodules, and symptoms of chronic meningitis. So the other thing that is important here, can cause disease in immunocompetent hosts. I have seen people that is in their 20s and their 30s that they come with meningitis and is Cryptococcus positive in the CSF. What are the risk factors for this? Cirrhosis, patients with HIV, solid organ transplant, or patients in immunosuppressive therapy. Okay, so Cryptococcus gattiae is usually in tropical and subtropical areas. However, we have a lot of those in the serotypes of Cryptococcus gattiae in the Pacific Northwest, specifically in Washington State. So what are the clinical manifestations of Cryptococcus gattiae? So they are exactly the same that Cryptococcus neoformans. So you will ask me, like, why are you talking about Cryptococcus if we already know how to treat Cryptococcus? So one difference with this specific this species of Cryptococcus is that the MICs for fluconazole are higher. So these patients, they tend to fail fluconazole therapy. So you need to be careful with that. So as Cryptococcus neoformans, you get these through the lungs, and after that you will have a dissemination to the brain, the kidneys, the skin, or the bones. So the diagnosis here, the principal method of diagnosis is cryptococcal antigen. This could be in the CSF or in the serum. And you need to be careful with the meningitis encephalitis panel because it has a high rate of false negative for Cryptococcus. So you may miss 30% of your cases. And something similar, just to do a parenthesis here, is that with herpes simplex, you can also miss 15 to 20% of your herpes simplex encephalitis. So if you think that the patient has cryptococcal meningitis, send a separate cryptococcal antigen. Or if you think that the patient has herpes encephalitis, send a separate herpes PCR. So how's the treatment with this? Is the same that Cryptococcus neoformans. If you have meningitis or disseminated, you will treat with amphotericin and flucytosine for 2 weeks. And after that, you will go through a phase of consolidation and suppressive phase with fluconazole. The duration of this will depend in the host and also will depend if you can stop or not the immunosuppression state of these patients. So where's the summary here? Okay, 59 minutes, it's pretty good. So the summary is for endemic mycosis, they can present with a plethora of clinical manifestations. However, the 2 main ones that you should know is you have a community-acquired pneumonia that is not improving despite appropriate antibiotics. And second is patients who present with lung with pulmonary symptoms, and they look like tuberculosis, but you do 3 or 4 mycobacterial cultures and all of them are negative. The other thing that you should know about them is that most of them are dimorphic fungi with the exception of Cryptococcus gattiae. The azoles are the mainstay of therapy for mild to moderate disease. Fluconazole is the only one that you will use for, fluconazole is just used for coccidioides. The rest, you can treat with the itraconazole, and amphotericin is usually used for disseminated and severe disease. Okay, guys, I don't know if you have any questions. I know that this was a lot of material. However, I mean that now you're ready at least to pass the questions in the internal medicine board.
Thank you so much for that, Christian. That was fantastic.